Good afternoon, all, and thanks for joining. My name is David Thompson. I work for Boston Scientific, a company dedicated and committed to transforming lives of patients around the world via innovative medical solutions. Moreover, in addition, as a part of our culture, we're also committed to addressing health inequities. And it's through our Close the Gap program, which for nearly 20 years now, has been executing programs such as this one with partners. And we're honored and pleased to be working with the Black Health Summit on this, on Black Health Matters rather, on this summit today. I presently work as the Vice President of U.S. Clinical Solutions in our rhythm management business. And I am joined today by Dr. Kenneth Stein, who's affectionately known as Ken. And for the duration of this panel, we'll refer to him as Ken, and you can send questions via chat to Ken. Ken is the Chief Medical Officer for the Global Chief Medical Officer for the rhythm management business at Boston Scientific. So before we get into meeting Ken, I'll just go to you and ask for you to share your background before we get going. And if you could just start with, at the risk of alienating some folks in the forum here, whether you are a Yankees fan or a Mets fan, and then you can tell us more about yourself.
Yeah, well, I wouldn't want to alienate any of the Mets fans out there, but I am a Yankee fan from childhood. My dad's a New Yorker. My dad grew up in Brooklyn, in Williamsburg, went to Boys High, and so he was a Brooklyn Dodger fan. And so my act of teenage rebellion is I really pissed my old man off by rooting for the Yankees and against the Mets. And then I spent most of my adult life in New York City, raised two wonderful daughters who both live there now as well.
Terrific. So you are a licensed physician. Could you tell us more about your background as a physician and your medical specialty?
Yeah, absolutely. And so I am a cardiologist. Again, did all my training in New York and was on the faculty at Cornell for many years. Actually, Dr. Icy Fergus, who was on with us a little bit earlier, was a colleague of mine at Cornell for a few years. I'm in a subspecialty of cardiology that's called cardiac electrophysiology. And what that means is, we specialize in abnormalities in the heart rhythm. We kind of divide cardiologists into electrical problems and plumbing problems. And I mean, I don't want to trivialize it because it sounds like I'm trivializing. I'm not. I mean, we have electricians and we have plumbers, and I work mostly on the electrical side. So, folks who need pacemakers, or folks who need defibrillators, folks who need treatment for a variety of different arrhythmias. And you and I both work in the same division at Boston Scientific that specializes in dealing with folks with rhythm disorders.
Terrific. So Ken, when we've heard a lot about just heart ailments broadly. Specifically, I want to talk about one area, and that's heart failure. What it is, what it isn't. A lot of people think that heart failure means heart attack. Could you dispel some of that and give us the detail on your perspective around heart failure?
No, absolutely, Dave. And yeah, I'm glad you said that, because it really is. It's a terrible term. I think that's with a lot of things in medicine. There's kind of the doctors. We all know what we mean when we're talking to each other, but it's highly specialized, and it doesn't come across, often doesn't come across clearly to patients and to family members. And so what heart failure means in essence is it's a situation where, for any of a number of reasons, and we can talk about what some of those reasons might be, the heart can no longer pump enough blood to meet all of the body's needs. And usually those are sort of the needs that you get when you're exerting yourself. Whether it's playing sports, whether it's maybe something simpler, like just trying to walk up or down a flight of stairs. As it gets worse, maybe it's just with walking on level ground. And eventually, if it gets so severe, the heart can't even pump enough blood to meet all of the body's demands, even when you're at rest. And so what that means for patients, right? Typically, the symptoms that you can get are symptoms that you get from not getting enough oxygen, because that's what the blood is carrying to your vital organs. And so folks get short of breath, and they may get short of breath when they're exerting themselves. They get short of breath with walking. May find that they get short of breath just at the end of the day when they go to lay down flat at night to go to sleep. And then the other sort of set of symptoms beyond breathlessness, again, very classically, is just fatigue, being tired all the time, or being more tired than usual, with activities of daily living or with physical exertion.
Thank you, Ken. And so I'm monitoring questions and they're coming in at a feverish pace. Could you differentiate between heart failure and sudden cardiac arrest? And also, in doing so, as we think about what we've been through the last 400, 500 days with COVID-19 and the pandemic, what have you seen, as impact of that disease, or that pandemic rather, on heart health moreover?
Yeah, absolutely, Dave. And I'm glad someone asked that question, because there are really sort of three things that can be confusing to people. And I may not only answer the question about sudden cardiac arrest, but because you brought it up earlier, the question of heart attack. And so a heart attack in medical terms is very specifically what happens when one of the arteries that supplies blood to the heart itself, and it's one of these things that you sort of think about. The heart's job is to pump blood to all the organs, but the heart also needs blood pumped to itself. And so there are arteries that supply blood and supply oxygen to the heart. And if one of those gets blocked, and it can be blocked because cholesterol is too high, can be blocked in folks with high blood pressure, smoking. But if it becomes suddenly blocked, a piece of the heart tissue can no longer get oxygen, and that little bit of heart dies. And so that's what we mean by a heart attack. Now, in the long run, if the heart attack is severe enough, and if enough of the heart muscle is affected and it isn't caught or treated in time, right, that can weaken the heart's overall pumping function. And that weakness of the heart's pumping function after a heart attack is one of the most common reasons that folks go into heart failure. It's not the only reason. Folks can also have heart failure, and I think this is particularly an issue in the Black community, where there's a very high rate of high blood pressure, hypertension. Is just having poorly controlled hypertension for a long time can actually cause the heart muscle to get stiff and not contract well, and that can cause heart failure. And there are a host of other things that can cause heart failure. I know we'll talk about COVID, and some types of very severe COVID infection themselves can weaken the heart muscle and cause heart failure. Now, sudden cardiac arrest is something different. And that again gets back to the plumbing, which is, right, that's the heart attack side of things, versus the electrical side. And that's the sudden cardiac arrest part of things. And so what we mean when we talk about a cardiac arrest is that the heart's own electrical system goes haywire. And so the heart, instead of contracting in a very coordinated fashion and squeezing a good amount of blood out with each heartbeat, can either stop beating or can just start this discoordinated quivering. And that kind of quivering is something that technically we call ventricular fibrillation. It stops the heart from being able to pump blood. And if it's not immediately converted back to normal, that will lead to death. And so that's sort of, when you see in the movies or on TV, where the EMS folks bring the paddles and shock the heart, right? That's a cardiac arrest, and that's doing something called defibrillation. And with that defibrillation, you can restore a normal heart rhythm and really literally bring someone back to life and prevent them from dying. Now, all three of these things are related in that, again, a heart attack, if it's bad enough, can lead to heart failure. But heart attack can also lead to a cardiac arrest, either immediately when you're having it, or just create a scar in the heart that makes you prone to having a cardiac arrest.
So Ken, you talked about race a little bit there. Around risk factors, another question's come in. Could you talk about the role that age plays in all of this? There are a lot of myths around you have to be old to have a heart ailment. Could you talk about that a little bit?
Yeah, I mean, I got a lot more gray. You don't have any gray hair yet, Dave. You're going to look forward to aging into the cardiac risk. And clearly, the older you get, the higher the risk is. Right there is just sort of accumulated wear and tear on the heart and the blood vessels, from living, and if you have some of the things that are underlying risk factors for heart disease, a lot of those accumulate over time. So, if you have high blood pressure, the longer the blood pressure is high, the higher your risk. If you smoke, the longer you smoke, the higher the risk. The good thing about both of those is they're treatable, or you can stop smoking. And once you stop smoking, the risk of heart attacks or the risk of heart disease really does start to fall off pretty dramatically and pretty quickly. Likewise, if you treat high blood pressure, you can undo a lot of the damage that may have occurred over years. Diabetes, another example. The longer you have diabetes, the higher your risk. Now, having said that, I want to come back to your question because I've sort of been dancing around it. But heart attacks aren't only a disease of old people, right? Can happen to young people. And again, the more of those risk factors that you have, whether it's high blood pressure, whether it's diabetes, whether it's smoking, the more likely you are to develop heart disease when you still are relatively young.
So, in so much and around as we think about treatments, just going back to the heart failure one, another question came in terms of treatment. Obviously, we are a medical device company, but there also are pharmacologic interventions around heart failure. Could you talk more about or delineate the difference between treatment via medical technology versus pharmacologics?
Yeah, and this gets back to why I was so glad you asked me at the outset about that sort of term heart failure, because it sounds so dire, and it is a serious condition. I don't want to underplay that, but I think we also ought to acknowledge there have been some really important advances recently in the ability to treat patients who have that weakened pumping function of the heart, and ability to help them live longer, and ability to help patients live better. And some of that is new drugs. And really, just in the last 3 or 4 years, there have been really 3 different classes of new drugs, all of which really dramatically improve outcomes in patients with heart failure. Again, it's one of the reasons why it's so important, if you have been diagnosed with heart failure, to make sure that you are being seen by a healthcare practitioner, and that you are getting access to these new and wonderful therapies. And then on the other hand, we also have the devices that you and I deal with. And again, in the device world, we have implantable devices called implantable defibrillators that, you get one implanted, it's like having an emergency medical technician, in your body. And so if you do have that sudden cardiac arrest that you talked about, it can defibrillate you just like an EMT can, and preserve your life. There are other devices that can help actually restore normal contraction and normal pumping function of the heart. And so I think the key message I'm trying to convey here is, even though it's a serious condition, today it's a treatable condition, and we have a ton of therapies, both drugs and devices, that can extend people's lives and can improve people's lives.
So Ken, as you think, a question came in, and I had a question in mind too, and I'll just combine the two. How should people or patients think about making sure that they're staying in front of debilitating heart issues, maintaining good heart health, and how can they also, in concert with that, enhance the relationships that they have with their healthcare providers?
Yeah, I think I want to answer that in two ways, Dave. The first is maybe a little more generic. The other one I think is really very specific to the Black Health Matters concept. And I think it's important, very important that we address it. And so sort of the generic answer again is, we are well aware at this point of a number of different things that predispose to heart disease. What's your blood pressure? If the blood pressure is high, make sure it's getting treated. What's your diet? Particularly with respect to, know what your cholesterol is. If your cholesterol is high, make sure that you're on a low-fat diet. And, if you need to be taking medication for cholesterol, do that. Please don't smoke. But I also want to point out something that's really important, which is, that heart disease, we know, disproportionately affects the Black population in the United States and the Hispanic Latino population in the United States. That's not because of any inherent genetic differences, right? I mean, we are, all of us, more than 99% alike. What it reflects is a disproportionate burden of what we call social determinants of health, but it's systemic racism. Heart failure is twice as common in Blacks in the US compared to whites. After getting a heart failure diagnosis, Black people are more likely to die than whites within the 5-year span. And part of that is because our medical system doesn't treat all patients and all people equally. And we know that people of color and women, and particularly women of color, are significantly less likely than white men to get referred for the kinds of device implants that you and I deal with for heart failure management. And so I think it's really important, for all the folks who are on this webcast, you need to be engaged, and you need to be an advocate for your own care. Ask questions. Never hesitate to ask for a second opinion. Any doctor who gets mad if you ask for a second opinion, they shouldn't be your doctor, right? And find providers that you are comfortable dealing with and that you can have frank discussions with.
So Ken, a few questions have come in. So in so much as COVID-19 has impacted heart health, question came in, should you run straight away to a cardiologist if you've been diagnosed with COVID-19 to assess your risk of further heart disease or damage?
I don't think you need that automatically. I think we do want to acknowledge COVID can directly impact the heart. It can cause inflammation of the heart tissue itself, and that can weaken the heart muscle. That's probably not as common as we were afraid it was going to be, early on, in sort of the dark days of the pandemic. You go back, sort of last March, April in New York. I think more of an issue with COVID are two other phenomena, right? And one is that just the stress of being severely ill, if you've had a bad case of COVID, can make any existing heart conditions worse. So, if you've already been diagnosed with a heart condition, right, and you have COVID, I mean, you certainly want to make sure that the folks who are taking care of you are aware of that pre-existing condition. I mean, I think the other thing that people really do need to bear in mind, and again, this was particularly an issue if you think back a year ago in New York, is folks were deferring a lot of care. Folks did not want to go in to a hospital or a doctor's office or a clinic, not because you had COVID yourself, right? And this was true of me. I mean, I'm not, I'm not talking about sort of some hypothetical person out there, right? But I felt really uncomfortable for several months, if I had to go in and get anything taken care of. And that deferred care, right, also, is then it's a missed opportunity to diagnose and to treat high blood pressure. It's a missed opportunity to help optimize the treatment of diabetes. It's a missed opportunity to diagnose any weakness of the heart function and put people on some of these new medications. And so I also think it's really important for those of us, who were putting things off for the past, year or so over the pandemic, particularly if you're vaccinated, it is really clear now, people who've been vaccinated are at very low risk of getting severely ill themselves, are at very low risk of passing the disease on to others. And so we got to just sort of get back into now all that kind of medical care that got deferred for the past year.
Yeah, a question came in, and I'll combine this one with another one. And you should have known there was going to be a question that came in around vaccinations of COVID-19 specifically. So one question was someone with evidence of heart disease in choosing, for whatever reason, not to get vaccinated. What are your impressions or thoughts about that? And then secondarily, more broadly, as we think about the vaccinations that have come to market for COVID-19, and how that plays in the grand scheme, when you think about clinical trials and clinical evidence on what's safe, what's not, and how to proceed. And your thoughts on that would be great.
Yeah, actually, I've been volunteering at a vaccine clinic out on Long Island. Had been doing it once a week, and it's now down a little bit, just because the demand isn't as much there. I think first of all, there are people who may have medical reasons the way they can't get vaccinated. And if you're unable to get vaccinated, then I think it is really important that you still adhere to all of the physical distancing recommendations that are out there, that you please do wear a mask. COVID numbers are down in the New York area right now, but down isn't the same thing as zero. And they're actually still a bit higher now than they were last summer. And so if you can't get vaccinated for whatever reason, then just please exercise the same caution that people have been exercising for the past year. On the other hand, is heart disease in and of itself is not a reason not to get the vaccine. And in fact, we encourage vaccination for everyone, but particularly encourage vaccination for people who have the most common underlying heart conditions that are out there. The vaccines have been very well tested in clinical trials, and now also just in real world evidence and real world use, not only in the United States, but across the globe. And we know that at least the 3 vaccines that are currently cleared for use in the United States are very highly safe and very highly effective at preventing anyone from getting severely ill from this really terrible virus.
Could you further define that? A question did come in as to whether or not getting vaccinated would eliminate the ability to further spread COVID-19. Could you hum a few bars on that?
Yeah, I mean, eliminate is that's just one of those words that we hate using and that the lawyers really hate when we use. Nothing's 100%, and right there are going to be some people whose immune system is weakened and they don't respond to the vaccine the way most people do. But I think what we can say is the vaccine very, very clearly makes it very unlikely that you yourself will get severely ill if you get COVID. And there's accumulating evidence now that the vaccines are out there that the vaccines really do significantly reduce any transmission of the virus, even if you have it but have a mild or asymptomatic case.
Thank you for that clarification. Well, Ken, we're up on time, and there were no comments that came into the chat regarding your affinity for the Yankees. So thank you for sharing your perspective with all of us. And folks, once again, I just reiterate Boston Scientific's commitment to addressing health equities. And, this is not the only program that we have done, nor will it be the last. It's just a part of how we operate. It's in our DNA. So with that, I'm going to turn it back. I think Rosalind Daniels, founder and president of Black Health Matters, has some closing comments. And she will be in the main session. So I think we'll just tap out of this audience. And thank you so much.
All right. Thank you, Dave.
Thanks everyone else for joining and listening in.